All right. Welcome back to the Psych Guys podcast. This is episode 30-something. We're going to be actually revisiting ADHD today based on a really amazing email we got from one of our listeners. So if you are listening to this podcast, if you have criticism, compliments, thoughts, topics you want us to touch upon, please reach out to us. It's easy. You can email us. You can find those emails right on the Spotify link or on our social media pages because we really want to engage with you. So let's get this started. So this was from one of our listeners. I'll just read this email in its entirety pretty quick. I found myself a little disappointed by the attitude that stimulants should be avoided when treating ADHD because of abuse potential as well as potential side effects. There are several things to keep in mind when discussing stimulants. Broadly speaking, all medications have side effects, and waving off the standard of care for fear of possible side effects goes against any evidence-based medicine. When prescribing, your role as the physician or leader of the care team is to weigh all the risks and benefits associated with any proposed treatment. If you discuss potential side effects with a patient or guardian, establish baseline weight, vital signs, cardiac risk factors, and sleep habits, screen for any comorbidities, there's no reason to withhold care. Many medications have the potential for abuse. Benzodiazepines have high abuse potential, but are valuable medications for treating several psychiatric disorders. Several antipsychotics have abuse potential. In addiction medicine, you treat patients with medications that have high abuse potential, and there's no reason to avoid them. Would you avoid pain medication in a patient when appropriate because there's a potential for abuse? I fear that without significant outpatient experience, you both haven't seen enough patients thriving on stimulants versus the very real psychosocial impairment that ADHD causes to understand how valuable and life-changing these medications are. This speaks to the value that you will see throughout residency. While stimulants are not the only treatment option, in fact, in children, behavioral interventions are also recommended and work incredibly well. We have seen few medications and treatments in psychiatry with near instantaneous effects, and stimulants are favored partially because you do not have to wait 4 weeks to see the benefits. There is a stigma against patients taking these stimulants, and your rhetoric could contribute to the stigmatization that these patients feel. I won't read the rest of the email, but it goes on to touch upon the DSM has changed roughly every 12 to 16 years, and we are now on DSM-5 TR that was released in 2022. So, Joon, what is your reaction to this listener comment?
Well, so the first thing I want to say is that this writer, addressed many different points in this wonderfully written email. So I think the first thing is we want to spend a majority of this episode talking about ADHD in the context of substance use disorders. However, as the email stated, there's also been mentions of like the changes in DSM. And I'm hoping if you're up for it, Logan, that we can get into those topics in a later episode as well. But for this one right here, I think because there's so much that we can talk about just regarding how to treat ADHD with comorbid substance use disorders, that's what we'd like to stay on, at least for this episode. The second point is I'm just going to echo your sentiment. I really appreciate this person taking the time to write this wonderfully composed, very well thought out response to one of our episodes. And I do want to provide a little bit of a context on where that came from. Because, as you're aware, not everybody listens to every single episode. And I'm going to be honest, that episode that we did, which elicited this kind of response, it's already been a few weeks, maybe even a few months. I honestly just vaguely remember what that conversation was about. But if my memory serves me correctly, I think I was telling a story about having a friend who was diagnosed with ADHD. He got stimulants. Long story short, he ended up abusing his stimulants. Just went for days without sleeping because he was just up playing video games, using Adderall. Eventually, I saw this guy who was a very, very good friend of mine, saw him fall into further substance uses. He started to experiment with other illicit street drugs. And long story short, he basically headed down a path where, that all his loved ones did not want him to go down. Mm-hmm. It was very heartbreaking for me to see. It was very hard for me to see. And it was at the same time very influential in my life. So I think, as physicians, right, we are human beings just like the rest of you guys. We come from our own unique experiences, from our own unique backgrounds, and those experiences, those unique experiences, I might say, have contributed to the way we see the world. And I think, that has to be acknowledged, right? Because not everybody sees the world the same way. And I'm bringing that up because I don't know if you mentioned it in the email, but there was, one of the questions that this writer posed to us was, how do we deal with bias, right? Our inherent biases. So first and foremost, I just want to address that. Yes, of course, every one of us has biases. It's not something that I think is, comes from malintent, or really it doesn't come from a bad place. It's just by the unique nature of the unique lives that we've led for, these decades. We just see the world in a very, very different way. And while biases sometimes can be harmful, I don't think there's any disagreement there. But at the same time, I think we also have to acknowledge that these kind of stories, these kind of experiences that we've had, is a part of our stories as well.
Right.
I mean, without that friend, I wouldn't be here right now. He was a big part of the reason why I became interested in the field of mental health in the first place. So yeah, that's one of the points that I would like to make. Do you have anything else just about the context before we really dive on into substance use disorders and ADHD?
Right. Well, I mean, and I want to get, outside of just even substance use disorder with ADHD, I hope that both of us weren't necessarily misconstrued on the last episode, and perhaps we misspoke. I never on this podcast, I want to be so rigid where I'm stuck in what I said. I know that I can perhaps missay things. I want to always evolve. And like I said, kind of keep that open-minded nature. And through some of this research, I have kind of evolved my attitude towards stimulants. But that being said, like you were saying, our experiences are in part how we think, right? And, me and you are in kind of the lower end of our, well, I guess now we're PGY3s, but, the first half of our experience in residency is very hospital focused. So I know you have, I've absolutely seen people abuse prescription stimulant medication. I worked at an addiction facility where I would have stories of these individuals telling them how, yes, the ADHD medication helped them do their homework and get through school, but they also enjoyed using this substance on weekends so they could stay out late partying even longer. So I think both statements can be true, that stimulants can help people and they also can hurt people too, right? Like that's like most medications, like opiate medications that was highlighted in this email. But, I think we have to acknowledge our bias. I think that it's impossible to say I'm going to be completely unbiased. I think that's an unattainable goal. I think acknowledging our bias, I probably am going to be a psychiatrist that is, I only want to use stimulant medications when I feel very strongly about it and that I've very much screened for comorbid conditions. And that's what I want to kind of get into this conversation with you tonight. Because quite frankly, I've worked with a lot of psychiatrists as even a pre-med student, as a medical student, and of course, family doctors prescribe stimulants too. I don't know. I feel like sometimes individuals don't always screen for these comorbid conditions. Maybe they just give the patient the medicine that they truly desire, that they truly want, maybe perhaps to build some of that rapport with the patient. But I always think about, is it like, are they doing that so they can get a good rating? That the patient experience on that survey when they leave, because it seems like so much of our healthcare policy is sadly because of those surveys. So I'm rambling. You take over. What do you think?
Well, I didn't think you were rambling at all. I think that was very beautifully stated. And before we get into the nitty and gritty details, I think one of the things that this person reaching out to us has forced me to do personally is to kind of re-examine my relationship with this podcast. Because I mean, me and you, we've spoken off the air, but there are times where it gets really difficult to, prep these episodes, to do research. Ladies and gentlemen, I'm a moron. Like the things that I'm talking about in this podcast, most of them I've had no knowledge of prior to coming on this episode. All that stuff
I disagree with you, but okay.
Yeah, I'm exaggerating a little bit, right? I do have the relevant experiences. Of course, I've gone through medical school and I've had a general interest in the field of mental health for a long, long time now. So I've always, been reading about the field. I've always been interested in philosophy. However, some of the nitty and gritty details is stuff that, isn't necessarily taught to us in residency. This is stuff that we're looking up on our own time, trying to come on this podcast with the most knowledgeable way that we can be, right? And we do try our best, but at the same time, I've had to acknowledge that I'm not gonna get it right all the time. In fact, I don't think that's gonna be my goal.
Mm-hmm.
I'm not afraid to be wrong. I'm not afraid to sound ignorant. I'm not afraid to make a fool out of myself on this podcast, because how the hell else am I supposed to approach this podcast? It seems like such a daunting task. We're talking here in real time, and oftentimes, there's things, we say things, and then I'll be like, man, I don't know why I said that. Let me go look it up, right? And I consider this podcast to be a part of my educational development as well. Logan, you're on here, you're asking me a bunch of questions. A lot of them, sometimes I just ramble. Like you said, you're rambling. And all I can do is go home, reflect on it, and maybe the next time I'm asked the same question, I can be better prepared.
Right.
So the first point is, I'm not afraid to be wrong. I'm not afraid to look dumb. I'm not afraid to look ignorant. But what I am afraid of, what I will not do, is stay that way. Right? We want this to be an experience where we're continuing to learn and continuing to educate ourselves. So with that said, right, we're going to get things wrong. So perhaps, we've said some things in the past episode that really didn't resonate with people. But I also want to point out that, especially when it comes to stimulant use, a lot of psychiatrists, like you just pointed out, Logan, they have vastly different approaches.
Right.
So I don't necessarily even think this is about being right or being wrong. But I would rather like to think of this podcast as an experience in showcasing that there's different psychiatrists out there that approach clinical cases in a different manner. And I think that in itself is a very, very important thing.
Right.
So with
and listeners, just so you're aware, I actually have a couple guests that I'm not going to release their names because they haven't officially committed yet, but I've at least approached them about coming on the podcast. And they both run ADHD specific clinics. And so these are individuals that I would view are extreme experts in the field, both of which are working with very high performance individuals, which is I'm really stoked about, because I feel like in our experience, at least mine in this residency, a lot of time we're serving impoverished populations, right? We're not necessarily seeing those individuals that have a lot of money that can afford a private practice psychiatrist who are working these, upper echelon professional jobs, right? So it's different. And, my bias over time, I'm sure, is going to evolve. But I feel like bias is also something that's inherent in nature to the world of medicine at the end of the day. What's that old phrase of medicine or seeing a doctor is go get a second opinion. It's like, well, why do we have that if we all have the same approach? It's like, well, because we don't. We all have our own bias, our own opinion, our own judgment. And so, all right, let's get into some of the nitty gritty here. What do you say, Joon? So
sounds like a plan.
One of the fact that I think is extremely interesting when it comes to ADHD and substance use disorder is that people who live with ADHD are 4 times more likely to develop a substance use issue throughout their life. And there actually is some data around that if you can treat that ADHD properly and sooner, those individuals are less likely to actually develop into a substance use. And I keep saying substance use disorder. What I really mean by that in more colloquial terms is like an addiction problem. Can you tell us a little bit about that study? I know you looked at it.
Right. So before we get into that, let's talk about this first, Logan. Why are we even discussing this topic? ADHD with comorbid substance use disorder. I think the reason we're discussing it is because to a lot of people, and maybe to even certain psychiatrists, it may seem counterintuitive to give that patient who's dealing with substance abuse another medication on top of it, which there's potential for abuse. Right. And just going back to that email from our writer earlier on, right, that was one of the points that was addressed. Yes, stimulants, there is concern for misuse. I'm just going to phrase it that way because misuse can happen in all different forms, right? Specifically with stimulant use, you're worried about one, addiction, overuse of medication, but also there's this real element of diversion as well. So I definitely understand where people are coming from, especially those that aren't in the medical field, when they kind of question like, hey, this person is addicted to cocaine. Like, why are you giving them Adderall on top of it? Right? I mean, that was the exact same question that I had in regards to, the story that I told about my friend when I was in, I think it was right after I graduated college. He was dealing with a lot of substance use disorder issues, and his psychiatrist continued to prescribe him Adderall and other stimulant-based medications. And at that time, I found myself wondering, like, what is this guy doing? Can't this doctor see what he's doing to my friend? How this medication is ruining his life, right? So just having been in that situation, when I'm seeing that patient now, just being on the other side as a physician, when I have that patient in front of me dealing with substance use disorders, but also dealing with symptoms of ADHD, and and I'm in a position where I'm having to prescribe stimulants, I sometimes find myself wondering, like, hey, is that person's family members, is that person's friends kind of asking the same questions that I myself was asking about my friend's psychiatrist a decade ago? And, I definitely sympathize with that kind of, with that kind of questioning. And I'm going to get into why. So, Logan, I want to direct your attention to the prescribing information for Adderall. So I'm going to have you look at two black box warning labels. One is for Adderall, one is for Concerta. These are both stimulant-based medications. Adderall is amphetamine salt, and Concerta is your methylphenidate. And here, I'm going to give you my phone. Here, check out what the black box warnings say. You can read it for each one of them for the audio listeners out there.
Well, and everybody, because no one's going to be able to read this in the small camera. But okay, prescribing information for Adderall. Amphetamines have a high potential for abuse. Administrations of amphetamines for prolonged periods of time may lead to drug dependence and must be avoided. Particular attention should be paid to the possibility of subjects obtaining amphetamines for non-therapeutic use or distribution to others, and the drugs should be prescribed or dispensed sparingly. Concerta or methylphenidate. Oh God, that's so small. Concerta should be given cautiously to patients with a history of drug dependence or alcoholism. Chronic abuse can lead to marked tolerance and psychological dependence with varying degrees of abnormal behavior.
Okay, so how does a rational person read that, and how are they not concerned?
Right.
I mean, it's right there. It's a black box warning, and it's written so directly. Right.
You don't have to be a medical professional to really understand that.
Right. Anybody would read that and they would be concerned. I mean, if you're a parent and your children are on ADHD medications, right, you're going to see that and you're going to have some hesitations. And again, I think that kind of hesitation, that kind of, worry perhaps, I think generally speaking, that all comes from, a place of concern, a place of caring for that individual. And I think all those concerns should be, I find it to be admirable because, Logan, we've been working in the psychiatric field for several years now. How often is it that we come across that patient who has no social support, who has nobody looking out for their interest, right? There's way too many people like that, unfortunately. So anytime you have somebody in your corner that's kind of raising red flags and kind of asking those questions, I think it's amazing. I think it's great. And I think it really speaks to the possibility that this person is going to have a positive outcome compared to somebody who doesn't have that kind of support. Okay, so why then do doctors still sometimes prescribe stimulant medications in cases of substance use disorders? Let's get into that, Logan. So like you pointed out, there's a lot of people who deal with ADHD that are also very susceptible to substance use disorders. So
they're statistically more likely to, right? Like
exactly.
They're 4 times more likely to develop some kind of substance use problem.
So there's a 2023 meta-analysis that looked at the prevalence of ADHD among substance use disorder populations, right? 31 studies were included in this meta-analysis, and the estimated prevalence of ADHD among substance use disorder patients was 21%. So 21%. I mean, you may hear that and you may think like, oh my God, that's so high. Or you may also hear that and say, oh, that's not that bad.
Right.
But let me put it into some context in the world of medicine, right? I'm going to use my favorite topic, side effects of antidepressants, right? When we talk about a medication like Lexapro, your classic antidepressant, what is the most common side effect? Dr. Noone.
Like tiredness or GI upset, I
GI
guess I
upset.
would say.
So nausea. That's
Yeah.
that's the number one thing, percentage-wise at least, that's listed on the prescribing information for Lexapro. What do you think that percentage is
For
nausea?
Oh, I think it's like 30 or 40%.
I think it's about 15%, 10 or 15%.
Okay. I thought it was more than that.
Yeah, exactly. So we're saying, when we talk about side effects, right? If 10% of our patients experience that side effect, we call that a common side effect.
Right.
So in this context, right, the comorbid rate of substance use disorders in ADHD populations is 21%, nearly double that. So that's a significant amount. And especially when we extrapolate to the general population, given that there's 350 million people in this country, is that right? Or is it 35 million?
Something like that.
I don't know. Yeah.
No, 300.
300? Okay, so something like that. So that sheer number, there's a lot of people out there. So why is that important? The biggest reason that it's important is because untreated ADHD can lead to worse outcomes in substance use disorders.
Right.
So what does that really mean in clinical practice? That means if you have a kid who has ADHD and it goes untreated, that person is more likely to develop a substance use disorder. That person is more likely to start using substances at an earlier age. And with that person is likely to develop an actual addiction to it. If that person actually does end up developing a substance use disorder and they have untreated ADHD, their chances of success in treatment for said substance use disorder is a lot less. If that person has untreated ADHD and they successfully complete treatment for substance use disorder, their chances of relapse is greater.
Right.
So we're putting patients at risk of dealing with a much more harsh version of their substance use disorders if we leave that ADHD untreated.
Right.
So, although it seems like non-intuitive, right? We're giving that patient addicted to cocaine, Adderall. Right. Why are we doing that? Because the data that's out there says that if we treat that patient's ADHD, we're giving that individual a better chance of combating their cocaine use disorder.
Right. And, there's a couple of things I want to say, some data driven and some more philosophical, I guess. So, I think you looked at this study too, but there was this big Swedish study that looked at, it was almost 40,000 people. It was over 26,000 men, over 12,000 women between the years 1960 and 1998. And it showed that when these individuals were used or prescribed with a stimulant medication, the individuals who got those stimulant medications are actually 31% lower to develop any kind of substance use issues. So it is, there's some clinical data supporting this notion that, adequately treating the ADHD can reduce the likelihood that someone is going to become addicted to these things. Now, that being said, I would push back a little bit and say, well, okay, but there's not a brain scan, there's not a blood test where that we can perfectly say with 100% certainty, okay, this is ADHD. Because ADHD can also easily manifest itself as perhaps bipolar disorder, dig fast, distractibility, and for you guys who don't know that mnemonic, that's the mnemonic that was buried into our brain for studying bipolar disorder. One of the components of depression, concentration. So maybe is this person really depressed, and maybe is that why they can't actually focus? And maybe even stimulants are part of the treatment for some of these issues, but it's just complicated, because I think that these stimulant medications can both help people with ADHD, but we have to also acknowledge the reality that these medications can absolutely be diverted and used for misuse. 1 out of every 6 high school seniors has experienced some prescription exposure to prescription stimulants, whether this was either medical or non-medical. Now, what I think is very interesting, I tried to do some research into diversion statistics around stimulants. And it's like, well, how do you really get at those statistics? Or how accurate are they, right? Because this is a crime. People aren't going to be very forthcoming about what's going on here. Did you get any statistics on what the diversion rates are that you found?
I did. So I have a meta-analysis from the Journal of American Psychiatric Association, for the one for adolescents and what is it, child and adolescents. So JAACAP. I forgot what that stands for, but yeah, that's the Child and Adolescents Psychiatric National Organization. So they did a meta-analysis of 21 studies representing over 100,000 subjects. Studies reported rates of past year non-prescribed stimulant use to range from 5% to 9% in grade school and high school students, 5% to 35% in college-age individuals. And I think that just echoes, your sentiment. These are very hard to measure, hence such a wide range, right? 5% to 35%, that's humongous. And also it found that the lifetime rates of diversion range from 16% to 29% of students with stimulant prescriptions who were asked to give, sell, or trade their medications. So the study concluded that individuals both with and without ADHD diagnosis and stimulant prescriptions misuse stimulant medications. Right. So when we talk about misuse, it's not just the person that's taking an excessive amount of it. It's also that person that's giving it away and supplying other people when they shouldn't be.
Right. And so I found a very interesting study that I thought was interesting. And then I want to kind of go into my own personal anecdote. So there was a survey of 9,161 college students in the United States. And there was a lifetime prevalence of prescription stimulant misuse was roughly 8.1% in this study. And they asked these individuals was like, okay, well, what is your drive to use this stimulant? What are you doing this? And 58% of the individuals said that they were using it for performance enhancement, helping concentration or increasing alertness. The second most frequently cited reason was for recreational purposes, getting a high. So I thought that was really fascinating. If we can, once again, this is only 9,000 college students. I'm not saying this is everyone in the entire world, but it seems like people are more driven to actually use this medication for performance enhancement rather than necessarily like the true abuse that we see with like methamphetamine use disorder, where they use these insane amounts, half a gram a day or something like that. The prescriptions of Adderall is I was listening to a podcast today, tenfold, if not even further, less than that. We're talking about anywhere from 20 to 30 milligrams roughly a day of Adderall. This is much, much less than someone who's using this medication to get high or whatever, right? I've personally related to this. Being that I am a psychiatry resident, I've had to take so many damn standardized tests. And me and you have discussed off air. I feel comfortable discussing myself. I'm roughly in like the 25th percentile of these stupid board exams in medical school. And a big portion of matching into a psychiatry residency at the end of the day is board exams. And whether you like it or not, out of all these professional schools, medical schools, law school, engineering schools, there is ADHD stimulant medication misuse for performance enhancement. And I would honestly kind of argue, like, is that really misuse then? Like these individuals are trying to misuse the medication to perform better on a test. And they're doing this out of not necessarily nefarious reasons, but their own personal interest. They're trying to, maybe get a better job, get into that better school, get into that better residency. So I remember I went to my psychiatric nurse practitioner because I was having some difficulties with focus, and I've always have. I do think it's in part related to my bipolar disorder. Do I maybe meet the criteria for ADHD? I'm not really sure. And so I asked that practitioner at that time in my life, like, hey, look, like, I wonder how I would do with a stimulant medication. I wonder if it would help me with doing better in school. And therefore, in doing better in school, maybe would I feel perhaps a little less depressed? Because at that time, my medical school experience was challenging. There was times where I thought I might fail out of medical school. It's a story for another day. She said, look, you're someone who lives with bipolar disorder type 1. There is a risk if I give you a stimulant medication that this could throw you into a manic episode, which kind of makes sense. There have been even psychotic features when I was manic that could perhaps get brought out by use of a stimulant. I have heard other psychiatric providers have a very different attitude towards someone who has bipolar disorder going on stimulants, or even someone who has like schizophrenia or schizoaffective disorder. Like if you adequately treat their psychosis or their mood features, that person can perhaps tolerate stimulant medication okay, but, there's a big risk. So I just thought it's just so interesting that the motivation to sometimes divert this medication isn't necessarily to get high, it's to do better on these tests. And so I would argue, is fixing this problem not necessarily from a medical perspective, but from a social perspective? Do we over rely on these standardized tests and all these tests in school to make these students do better? Because I get that stimulant medications can help a person perform better on a test, but is it also making them more anxious, maybe more paranoid? Maybe not necessarily to a point where they have to go in an inpatient psychiatric ward, but is it fueling this anxiety that so many people can relate to?
Had a friend in medical school who was using stimulants that were not prescribed to him. Long story short, he had a panic attack, ended up in the ED.
Wow.
Yeah, so it does happen. But, I think about that friend, right? And, I could definitely relate to the pressure that he was under because I was, I was in the same goddamn school. I was going through the same exact situation as him, facing this monster of an exam, USMLE step 1. There's a lot of pressure for you to perform really, really well so that you can hopefully match into, the specialty that you want. Right? We're investing hundreds of thousands of dollars into a medical education. And if you don't perform on this test, you may not get to do the job that you've always dreamed of doing. Mm-hmm. Right? So when you have that reward on the other side, right, there is that inherent motivation to do everything that you can to optimize your efficiency, your ability to learn. And I do think that system inherently places a lot of pressure on medical students, right, which is why we see sometimes some of our students who may want to potentially use stimulants that are not prescribed to them. So the question I have for you, Logan, is is that really going away? I feel like if anything, it's going to get worse. The population is growing. There's going to be more and more competition for a limited number of spots. With just the way our economy is headed, life is just becoming objectively tougher, right? There's more pressure for you to make more of an income if you want to have the same standard of life that somebody a generation ago did, right? And all these things, I think, places a lot of pressure on students to do everything that they can. And if you see your classmates doing that, if you're in a class of 50 people and 40 other people are taking stimulants, are you at a disadvantage?
And maybe that was the stats that we were up against in medical school. I would love to truly know what the stats were of how many of my colleagues were actually using.
It's not something that people readily disclose, right, but we know.
Right.
We know what's happening.
Well, and what I would push back against that, obviously in our little bubble of medicine, I do actually think there's an over-reliance on board exams, on MCATs. I think that they have their place, right? Like you have to have aptitude to do this job. You have to be a certain level of intelligence. I get that. But, man, when in this job is anyone ever sitting down for 8 hours at a time, clicking buttons, getting asked 260 questions in a row? I really think not. Even that neurosurgeon who's doing an 8-hour long, operation, come on, we can develop better testing strategies for individuals like me and you who are, going in this world of psychiatry. I knew I wanted to be a psychiatrist much earlier in my medical training, I think, than you did. It was, day one. Why wasn't there specific testing for me? Why wasn't there specific modalities of testing my interview skills, testing my ability to interact with people? I would think long and hard about how I actually think I could be a more productive, a better psychiatrist if I spent less of my time in medical school learning histopathology and spent time freaking learning Spanish. I think I could do a better job for my patients. These days with the world of the internet and the computer, and you're basically holding a computer in your phone right there, we can look up all this information. So I think that really, in a way to almost fix this issue and address this issue, we kind of have to change our educational system as well, because now I wish I had the true data around this, but I know you've ran into this fact too. I mean, the prescription of stimulants for ADHD increased sixfold from 1995 to 2008 at an annual rate of 6.5% in adolescents. I really wonder what those are today. You know, we saw an Adderall shortage in this last, year or so, with all these online prescription, pill mills, as we would describe, and these. I love telepsychiatry, but there's definitely some drawbacks there that it seemed like these evaluations weren't really adequate and just giving people whatever they wanted. You know, if they pay the fee, okay, here's your prescription. Bye-bye. On to the next one. What else did you want to say on this episode?
Right, Logan. So we've just spent a lot of time discussing potential for misuse in the world of medicine, in medical schools, maybe even residency, in our own little bubble. But I think it extends beyond that, because I think it's a pressure that a lot of us feel, especially the younger generation, no matter what field that they're in. And we did a whole episode on hustle culture. There's a lot of pressure on, young individuals these days to perform, to make money, to be quote unquote successful in the stereotypical ways that the world would define success, right? In terms of, materialism, in terms of being able to, display a certain level of wealth, a certain level of standard of living. So I think all that contributes also to pressures that people may feel to, either go try to get a ADHD diagnosis, or even try to obtain stimulants illegally. So I think we've established that the concern for misuse of stimulants is very real, and it's something that physicians are aware of. And we kind of discussed earlier that, when you treat somebody with ADHD, they have a better chance of, overcoming their substance use disorders, or at the very least, hopefully they'll have a less severe version of it. But I want to stress that doesn't mean that physicians are oblivious or physicians completely ignore the reality that's out there, as we spent the last 10, 15 minutes discussing.
Right.
The concern for misuse is very real. So the next question then begs, what can we do to mitigate some of the risks of misuse, given that patients with substance use disorders can benefit from it, and the evidence says that they in fact should be treated for their ADHD symptoms. So what can we do to mitigate, in that individual, the chances for diversion, the chances for abuse, and ultimately, giving that person a chance to have the best possible outcome. So I think there's a few simple tricks that a lot of physicians use, and I'm going to try to outline a few of them. So the first thing is in the choice of medications that we can recommend to our patients, right? Yes, stimulants work for ADHD and they work great. That's why it's used very, very commonly and very often. But I'd argue that in this special subset of our population and those patients that are dealing with substance use disorders, it may not be the best first line option. It doesn't mean that it can't be considered later on. It doesn't mean that it shouldn't be considered later on. In fact, in many cases, it is often considered later on and often prescribed. But I would argue that the first choice should be a non-stimulant based medication. And I'm going to refer the readers to a resource called Simple and Practical. This is something that I read a ton of in residency. It's just basically a very practical guide on how to manage some of the clinical issues that we see very commonly here in the hospital. And shout out to Simple and Practical for teaching me this fact and many other things.
Are you saying that's first line for ADHD period, or first line for ADHD in the setting of potential substance?
In the setting of substance use disorders, okay. When we have a high suspicion or high concern for misuse, we can always use a medication like Strattera. Right? These are non-stimulant based medications, and there is evidence that it's helpful in ADHD.
Right.
Also, another medications that I see a lot of providers use is Wellbutrin. Generic name is bupropion. It's thought to have a little bit of stimulant-like properties, but it's actually an antidepressant. So I do see that being prescribed a lot. However, the evidence for that is not as strong as Strattera. So I think that would be a great first option. And let's say we get to a point where we do need to use stimulant medication, right? The Strattera is not working. So say we've tried several different agents and we need to be more aggressive. We need to start considering stimulant medication. One of the things that we can always do is go for that extended release formulation, right? We know that the faster the onset of action is, you're putting that person at a higher risk for addiction, right? You take a medication like, let's say like Vyvanse, right? That's going to take it's going to take a while for the active ingredient to release into your bloodstream because it is a prodrug. And what does that really mean? It means that the time that it takes to titrate up in your bloodstream is a lot slower than something like an instant release formulation. And on the extreme end of that instant release formulation, to take a drug like cocaine, right, takes about 2 seconds for it to kind of shoot up in your bloodstream, and that's why you feel the effects immediately, and that's what keeps you coming back, that instantaneous, elevated, and really pronounced dopamine hit that you're going to get. So by using extended release formulations, we can kind of mitigate some of those concerns. Another thing that we can do that's non-medication based, and I think this is a great option for a lot of families out there, and let me preface this by saying that this is why I believe it's so important that anybody dealing with any kind of mental health condition needs to have that family support. That's going to speak volumes to their potential, how they're going to potentially recover from their illness, right? So we can always ask a family member to provide this individual with maybe just a day's worth of medication, maybe just for that week, and make sure that they're not getting, a whole bunch at once, right? Great choice, especially in like college students where you have, concerns that they may be diverting or even misusing the substance themselves, right? And on that note, we can also think about like, what has lower street value, right? So according to, Simple and Practical, Ritalin also, it has a lower street value than Adderall. Right. So we can always think about stuff like that. But I think, my personal favorite is just asking your mom and dad to like say, hey, like just give me the days, just give me 1 week's worth of medication at the time. If you don't have that available to you, you can always ask your doctor to do that for you. It's my understanding that, depending on the state that you live in, you can get up to a 90-day prescription of stimulant medication here in the United States. Here, where we practice, I think we're limited to 1 month. Or
that's
at
my
least,
understanding.
Right. That's the most commonly used duration that I see. But you can always ask your doctor, like, hey, why don't you just give it to me in 2-week increments? If you can handle it, why not 1-week increments to kind of give yourself that check and balance system?
Right. And, I guess what I would want to just really kind of echo here is that, look, management of ADHD can change with time. That there's a couple different or 2 different types really of ADHD, the inattentive and then the hyperactive. And my understanding of ADHD is hyperactive seems not all the time, but a lot of the time as someone ages, adults are less hyperactive. We're just more tired, right? Not bouncing around like a little kid. But that inattentiveness may still be there. But the treatment of ADHD may evolve with time, potentially as your cardiac, heart issues change with time. But also I'll share kind of a quick story of an individual that I had who was a very successful man, doing extremely well, worked in the finance sector, and he was on a high dose extended release Adderall. And he was struggling with insomnia and anxiety and mood issues. So kind of our first thought was, hey man, we should maybe reduce some of that Adderall, or maybe this isn't a good medicine for you. And what I've really experienced is a lot of individuals kind of attach their identity to that Adderall, or, hey, it's my lifeline. Like, I can't do my job without this Adderall. And like, kind of like what you were talking about, the pressures of society, like, oh my God, I can't do this job. Maybe I can't provide for my family. That's even going to make me more anxious, even more depressed. But I do think, like we kind of started out this podcast, I do think that we need to be open-minded, open to suggestions from a psychiatrist or a psych nurse practitioner, or really any provider out there that, adjustments potentially need to be made with time. There are new research out there that potentially rapid transcranial magnetic stimulation therapy might actually be an intervention that we can do to treat ADHD. Has there been much data and research into, can psychedelics play any role with ADHD? I really have no idea. I'm not going to say yes or no, but there are the future of the treatment of psychiatry could change. So I just don't want to have practitioners be so rigid in their thinking, and also patients either rigid in their thinking that times can change. I want, both me and you to evolve in our understanding and approach to ADHD with time. And I hope our patients and our audience is open-minded just like us.
Right. And one last thing, just like with mild depression, mild ADHD does not be, it doesn't necessarily have to be treated with medication all the time. In fact, I would suggest that the first thing that anybody with ADHD does is receive CBT. I didn't know this at the time, but researching this episode, there's ADHD focused CBT, which can help with skills regarding organization and planning, navigating distractions, and development of adaptive thinking skills, and also the reduction of procrastination behaviors. And again, they looked at this. They looked at CBT for ADHD in a group of 88 college students, and it showed that their improvement in symptoms of ADHD remained stable 5 to 7 months after active treatment concluded. So like we always say about CBT, yoga, meditation, mindfulness, these are techniques that you can carry on with you. Versus stimulants, other medications for ADHD, they're only as good as long as you're taking them. So that's the major pro for non-medication based treatment modalities when it comes to ADHD and a host of other psychiatric illnesses.
Right. And then I'll just refer the listeners to on my other podcast, Talk Mental Health with Logan Noone, I brought on one of my great friends, Tommy Barker, and he did some research as an undergraduate student. He's currently an emergency physician now, about attention restoration theory. And what this had to do with at the University of Utah, they did some research into getting individuals outside and how that impacted their ability to focus, and how they actually even would put up pictures of like outdoor seascapes in jails, and they tested the inmates on their abilities to focus, and it actually had an improvement. So, look, there's a lot of different approaches here. I think this was an interesting episode. We're going to continue to revisit ADHD. Hopefully we'll have on those expert guests that I referred to earlier. And thanks for tuning in. If you guys made it this far, man, please give us a 5-star review and a 5-star rating and a review and a subscription. What other things?
Yes, please.
Click all the
Everything.
bells.
Do it all.
Click all the thingies. I don't know. Whatever. Thank you for tuning in.